Okay guys, so today's video is one of the most interesting topics that I've ever researched for my blog and for my YouTube channel. We are going to be talking about brain surgery as a treatment for severe addiction, all the way from frontal lobotomy in the 30s, 40s, and 50s through one specific technique that I'm going to be focused on today, which uses electrodes implanted into the striatum, which is a part of the brain whose function I'll explain, in order to cure or at least drastically reduce the symptoms of addiction. So if you're new here, welcome to the channel. My name is Brian. I have an addiction and recovery blog that I've been running for over a year now called the Concrete Confessional Blog. I'm a science teacher. I teach biology and chemistry, and I have been addicted to benzos and opioids for 20 years now. I've been on and off of these substances. At the moment, I've been off of benzos for well over a year, and I'm currently in the final sort of third of tapering off a high dose of methadone maintenance treatment. So that's who I am and where I am right now, and without too much procrastination, let's get into the good stuff. So the way that I thought I would structure this video is I would briefly talk about the neuroanatomy involved in addiction. I'm talking like 2 or 3 minutes that you will totally understand as long as you have like high school level biology, and probably even if you don't, okay? After that, I'm going to talk about specifically how this deep brain stimulation works as a treatment for severe addiction. I'm going to talk about some of the limitations and risks involved with the procedure, and then we're going to look at a couple of the studies that analyze the results of the phase 1 trials through West Virginia University's Rockefeller Neuroscience Institute, which was one of the organizations that sort of pioneered this DBS treatment that we're going to be talking about today. I'm also going to consider, again, some of the limitations. One of the coolest parts of this research and of the video today will be the quotes that I found from 3 of the original patients who had these electrodes implanted into their striata. They had incredible things to say, not just about how it affected their addiction, but also how it affected things like in one participant, he said it cured his fear of public speaking, which is incredible, and of course an unanticipated effect of the procedure. So reading their accounts was probably the coolest part of this whole, again, very, very intriguing research process. So I'm going to go over that, and then I am going to talk about just sort of what I think the outlet is, or not outlet, but outlook is for this kind of procedure as a treatment for addiction. Again, talk about some of the financial and other limitations, some of the practical limitations involved, and mention one other West Virginia University study that is using a less invasive brain technique to reduce cravings. So that is kind of how it's going to go, and without further ado, I guess we will just get started. But before I jump into the neuroanatomy, I want to talk briefly about addiction in the United States right now, and opioid addiction in particular, okay? And I repeat this stuff until I'm blue in the face for a reason. There has, as far as we know, never been a society so addicted to really dangerous drugs as the United States is right now, particularly in terms of opioids in general and fentanyl specifically, okay? We're losing upwards of 100,000 Americans every single year to overdose alone. Most of those are opioid overdoses, often in combination with other drugs, particularly other respiratory depressants like alcohol or benzos, okay? It has been, meaning overdose, not even just addiction generally, but overdose specifically has become the leading cause of death for Americans under age 50, which is, that totally turns on the head the normal causes of mortality in young people, which tend to be like car accidents, sort of gunshot accidents and other misadventure type deaths, and it's just totally unprecedented to have this many young people dying of drug addiction generally and overdose specifically. So we have a huge problem. It is, in many ways, a national tragedy that, in my opinion, eclipses almost any other problem that we've got going on right now. So I bring that all up to say I have always advocated opioid addiction has the highest mortality rate of any mental health issue at the moment in the United States, okay? And it has a mortality rate comparable to the most severe and feared of cancers. So given that that's the case, I have always advocated we need more experimental treatments. We need doctors who are going to take risks. And traditionally, doctors operating in addiction medicine haven't been able to do that because they have their hands more tied than physicians in almost any other specialty, which is such a sick and perverse restriction, given that, for example, the pain management doctors who are actually creating the addiction in our country, they are relatively unencumbered in terms of regulation. So it is a totally inverted clown world when it comes to what our government allows and doesn't allow. The Sackler family still hasn't been punished for essentially kicking off this whole, addictive holocaust. So don't even get me started on that. But again, all this to say, we need doctors who take risks. This institute at West Virginia University, again, the Rockefeller Neuroscience Institute, that is pioneering these sort of radical, revolutionary addiction treatments, thinking outside the box. They are doing, in my opinion, God's work, or if you don't believe in God, they are doing just the most utilitarian good possible. And I can't say enough how important this was. I read the other day that for every person who has been infected with HIV, there has been $3,000 US devoted to developing a cure. For every addict that we have, there's been $3 devoted to developing a cure. So when you really think about that, it's like we don't even know how much we could have advanced treatment because we just haven't put the money into it. So again, all that to say, we need more projects like the one I'm talking about today. Okay? So I want to talk a little bit about neuroanatomy in general briefly, okay? And I'm going to throw up a slide that shows the brain, and it shows the brain divided into 3 primary regions, okay? The regions are the forebrain, the midbrain, and the hindbrain. And best way to conceptualize this is the hindbrain is the most sort of, in terms of evolutionary history, it's the oldest. It's like the reptilian brain. It controls the most basic functions. And then you progress through the midbrain and finally get to the forebrain, which is the most recently derived structure. It is the most embellished in humans and chimpanzees and other monkeys and apes that have a lot of cognitive faculties, a lot of communicative faculties, a lot of just higher consciousness and ability to reflect and that kind of thing. So from the brainstem, and specifically the hindbrain, moving up to the forebrain, you go from relatively simple to increasingly complex and social and reflective functions. So the hindbrain, for example, contains the pons and medulla. It's a lot about regulating body rhythms, regulating temperature, basic pattern recognition. Again, so you can think of it as sort of the reptilian brain. As you get into the midbrain has a lot of, it's sort of a relay center. It has a lot to do with relaying signals related to movement, audio and visual processing. And then as you get into the forebrain, so the forebrain has what we call the cerebrum. It has what we call the cerebral cortex. So that's the very convoluted, the very sort of, it's got a lot of sort of ridges and furrows. It's all turned in on itself. And the cerebral cortex is where almost all of our higher order functions, the things that make us uniquely human, the things that we associate like with soul and with consciousness, that's where those are seated, okay? So the cerebral cortex handles everything from, sensory inputs and motor outputs at the conscious level, not for input but for output, obviously, but handles everything from that to, again, like executive decision making. It handles, like, it has to do with personality and motivation and reward and planning. So that's kind of the most basic breakdown, and that breakdown is woefully inadequate because all these areas of the brain are overlapping. There's no area of the brain that just does one thing in isolation of all the other areas of the brain. It is unbelievable how interconnected things are. The brain is divided into 2 hemispheres, and you'll see labeled on this chart the corpus callosum, which is a set of fibers that connect the 2 hemispheres, and there are fascinating things that happen when you sever that connection, for example. You'll also see, just as a general science teacher in me wants to tell you, you'll see these sort of what look like openings or spaces. They're filled with, these are called the ventricles of the brain, and you'll see that the midbrain in particular is structured, it's sort of formed around these ventricles, and they're filled with cerebral spinal fluid, which circulates through them and ultimately communicates with the spinal canal and the spinal cord. So those are just kind of some of the key structures. You'll also see that there are some neuroendocrine structures, specifically the hypothalamus and the pituitary gland. So those are hormonal structures where the nervous inputs connect with glands that actually make hormones. So you get those outputs, and then vice versa. You have sort of, not vice versa, but you also have neural structures that monitor the feedback coming from those hormone levels and from the areas of the body that the resultant changes affect, so that if it needs to be tweaked up or down, that can happen. So again, forebrain most recently evolved. We kind of associate that with our uniquely human properties, a lot of stuff about personality, planning, executive decision making. Midbrain is a relay center, especially as regards motor, audiovisual processing, learning, and a lot of other functions. And the hindbrain is the most basic level of the brain. It's the most ancient, and it has to do with basic bodily rhythms, keeping things like temperature and other basic physiological parameters in line. There's also, you see the cerebellum coming out of sort of the back of the hindbrain, and that has a lot to do with balance and coordination. So I think that's a decent overview, and for the record, addiction affects every single level of the brain. In terms of structures that we'll talk about today, addiction really atrophies and damages a part of the cerebral cortex, so we're talking about forebrain, called the prefrontal cortex, okay? And that structure specifically has to do with planning, delayed gratification, and impulse control. So what you see in addicts as time goes on is that they have less and less ability to restrain their impulses. They have less ability to plan. They get stuck in this survival and impulse driven level of existence. And again, it's the prefrontal cortex is structurally damaged by long-term addiction, which then removes you, or I should say it damages the faculties that you need to get yourself out of addiction. Because if you can't make the decision to not give in to that instant gratification, you can't, sort of like build your PFC back up and heal from addiction. So we're going to talk about a fascinating finding of one of the studies on this DBS technique later on in this video, where we see that some of that damage to the PFC was reversed in certain participants in these studies following DBS implantation of these electrodes. Okay, so the PFC is profoundly affected in another area that we're going to talk about today, which is technically part of the basal forebrain. So it's sort of like the lowest part of the brain that's technically still considered the forebrain, but it communicates extensively with the dopaminergic, the dopamine producing neurons of the midbrain. Okay, and that structure is called the nucleus accumbens. And this is when you hear those that term pleasure center, the nucleus accumbens is one of the most important ones. So when we take addictive drugs, they release dopamine in the nucleus accumbens and in other pleasure centers of the brain. Okay, what happens over time is we become addicted to that. So some of us are predisposed to this to begin with. We know that addiction has a significant genetic component. And so, for example, some of us have genes that produce dopamine receptors that are less reactive. So because we're not feeling such a high level of natural stimulation, we don't get that natural kick of pleasure that a lot of people get from a lot of sort of basic activities, we tend to seek it. We're stimulation seekers. And in the modern world, that often correlates with taking drugs. And the problem with that is, drugs will give you more dopamine in the nucleus accumbens and the other pleasure centers of the brain than anything else. They outpace sex, they outpace, corn, they outpace great food and so many other things that sort of naturally give us rushes of dopamine. They can do that times 10 or even times 100 in terms of the levels of dopamine produced. But when they do that, we over time start to require that. Our body gets even poorer at producing dopamine by itself because it sees I don't really need to do this because I have this exogenous drug, this drug from outside the body that is doing this much more efficiently for me. And so that what you see over time is that the natural level of dopamine production and the stimulation of that dopamine release by our own physiology is degraded in drug addiction. So when you stop using substances, you no longer have whatever natural level of dopamine production that again gave you that sense of excitement and pleasure and fulfillment which you had before your addiction. So what you see is different substances how should I put this, the addictiveness of different substances is highly correlated with how good they are at enhancing dopamine release in the nucleus accumbens and the other pleasure centers of the brain. So, for example, you see alcohol, I think it's relatively modest. It might increase, so good food might increase dopamine in these pleasure centers by like 50 to 75%. Drinking a lot of alcohol might bring you up to like 100, 150. Opioids in cocaine and some of the stronger drugs will bring you up to maybe 400 to 600 or 700%, depending on the the specific substance involved. Meth is the king of dopamine production, and it can boost it by like 1200 to 1400%. So what you see is the primary symptom of meth withdrawal is not physical sickness like you get with opioids, which is incredibly debilitating, but it's this profound anhedonia. Anhedonia literally means lack of pleasure. Okay, so people who have been on meth for a long time and they get off of it, they just can hardly get out of bed in the morning because none of the natural reinforcement in activities like eating, for activities like talking with friends, for activities like forming new friendships and romantic relationships, none of that can A, compare to what meth gave them, or B, be felt after their brain has been ravaged by years of artificial stimulation of those systems by meth. So that's one of the reasons why the meth recovery rates are so low. So yeah, that's just a quick overview of the neuroanatomy involved, and gonna get into now, we've known that you could potentially use brain surgery to treat or cure addiction for well over 100 years at this point. Now, the original technique that was proposed for that purpose was lobotomy. If you don't know what lobotomy is, it was called transorbital frontal lobotomy. Transorbital meaning the doctor took a probe, put it underneath the eye, tapped it with just this little hammer, and used that to very crudely destroy whole areas of your cortex. Okay, so as recently as 1952, the Journal of the American Medical Association, which is like the gold standard for medical publications in the US, it published a study on the effects of frontal lobotomy on opioid addiction in particular. Now, when they were setting up what they were doing with lobotomy, the authors noted prior clinical data that showed that lobotomy attenuated opioid withdrawal, and that it also reduced or eliminated addictive usage of drugs in opioid addicts. So there was some benefit to this. But when you talk about the phrase brain surgery with a butcher knife, lobotomy was literally brain surgery with, if not a butcher knife, then a very non-discriminating probe. So there were so many effects on every aspect of someone's personality and functioning, and because of that, there were oftentimes really bad effects that were the opposite of what was intended. So, for example, you might think frontal lobotomy, you knock out the centers that involve like sort of decision making, and you'd think someone would become very passive, but you could just as easily damage whatever prefrontal cortex function they had remaining, in which case they would have no restraint on their impulses. Any of that restraint that was there would be gone. So it was a very sort of like crude technique that was way too unpredictable, but it did help. I mean, it did in some addicts reduce withdrawal symptoms and reduce basically usage of drugs and other impulsive behavior. So what's really interesting is that Chinese scientists have done a lot of research on this since the People's Republic became a country in 1949. If you guys have watched my content, I spent several years in mainland China. It is my second home, and Chinese scientists have made incredible discoveries around this issue. Now, they're very pragmatic, and they didn't have a lot of the restrictions that Western scientists had when it came to experimenting on humans, particularly because drug addicts are viewed as almost subhuman in China because of China's history with mass opium addiction during the Opium Wars in the mid 1800s. So long story. But anyway, Chinese scientists have looked at this issue and they have experimented with a bunch of neurosurgical procedures to treat addiction. Okay, so they have also worked with lobotomies. They have also used ablation. They've basically burned away certain pleasure centers in the basal forebrain, the midbrain, and even the hindbrain. Okay, and finally, they have used. We'll talk later on about a study involving 8 participants where they used a very similar deep brain stimulation setup to the one that we're going to talk about today. In fact, Chinese scientists pursued these surgical techniques for treating addiction so enthusiastically that the CCP, the Chinese Communist Party, was actually forced to ban certain procedures in 2004. The issue was that the surgical procedures that were employed obliterated whole swaths of neural tissue, which, again, they had really broad functions on desire, reward, and pleasure, meaning that they produced wide-reaching, undesirable effects on personality when these structures were ablated, especially in regard to motivation and contentment. Okay, so that was a pretty rare step in by the CCP that said, don't do this anymore. And by the way, all the studies and articles that I mentioned today are listed in the order in which I mentioned them in the description for this video with links. Okay, so if you want to go right to the source, that is there for you. Just want to note quickly before we get into the DBS setup through West Virginia University specifically, that when I was in my 20s, as drastic as getting electrodes implanted into your brain seems, I would have considered this procedure. I was ineffably demoralized. I was trapped in this cycle of interminable cycle, like literally dozens of times. I went through relapse. Okay, you're relapsed, you're going to go to inpatient treatment. Okay, you have 30 to 90 days of being completely clean or maybe being on buprenorphine maintenance. So the optimism comes surging back. You get out, you get a new apartment, a new job. I'm doing well for a few months, and then there's something I could just felt pre-programmed almost, and I could not stay clean. And my friends, particularly when fentanyl came into the U.S. illicit opioid supply, my friends were dropping like flies. And I truly felt every time I lost a friend, I thought, well, that's them, and next week it's going to be me. So if competent sounding doctor or scientist had approached me and said, hey, you want some electrodes in your brain, like this might help, I would have done it. Now, I don't know if that would have been the right decision, and I certainly wouldn't consider it now. But I just want to point out, again, like opioid addiction has a prognosis currently on the same order of magnitude as the very most deadly cancers. So it's not crazy to think about a procedure and intervention that is this serious with this many potential risks. Okay, for any other disease that killed this many people, we would be pretty open to that. I think with addiction, we get caught up in the perception that, oh, the person could just stop if they wanted to, even though the lived reality of addiction and all of the data, right, millions of deaths of people who didn't want to die, contradict that idea. It's really hard for people normal people to understand that, like, you can't just stop when you get trapped in that a state of advanced addiction, which I'll talk more about in just one second in the context of OCD. So I would have considered doing this procedure. Yeah, that's just the truth of it. Okay, so now I'm going to talk a little bit about how this deep brain stimulation technique that West Virginia University's Rockefeller Neuroscience Institute and Medical School are using in these studies, how it works, okay? So this same kind of setup, by the way, has been used to treat Parkinson's disease, because in Parkinson's there is a deterioration in the dopaminergic neurons that are involved in movement and other functions. Okay, and also in OCD, obsessive-compulsive disorder. Now, why do I say that latter part about OCD is important? Well, I talk a lot on my blog and on my YouTube channel about how if you love an addict and you don't know how to think about this disease, the most accurate way I can give you to think about it is that addiction is like a very severe obsessive-compulsive disorder, very similar in terms of OCD in regard to anxiety, compulsion, ritual, reward. I often, again, explain this as just OCD is like, or addiction is like an advanced OCD that is, instead of about contamination or other issues, it's about the anxiety and discomfort and obsession of having a substance in your body without which you can't function. Okay, so addiction is really just like an OCD geared around the level of the substance in your system, if that makes sense. So you get this unbearable anxiety when you know that substance is leaving your system, and you've got all these rituals around re-upping that substance in your system. And if you don't do what you need to do to get that substance in your system, the like fear and dysphoria is out of this world. It's something that you truly can't appreciate unless you have experienced it. It feels like hell on earth. It feels exactly like what I would picture hell is like, except here on earth. Okay, so it's not coincidence that this kind of setup, this deep brain stimulation setup being used by WVU in this study, also works for OCD. And the fact that it works for severe OCD is actually some support for the idea that it will work in addiction, because some of the neurological and neurological changes that are seen in OCD are also seen in addiction. And again, they're very similar pathologies. Okay, so in this specific protocol that's employed by WVU, you have small electrodes that are implanted into a part of the brain that's called the striatum. Now this again is in the basal part of the forebrain. It's a group of interconnected nuclei that play a role in motor function as well as emotion, habit formation, and reward. So specifically, the DBS procedure that we're talking about targets the nucleus accumbens, which I touched on before. It's oftentimes referred to as one of the dopaminergic pleasure centers of the brain. So that neurotransmitter dopamine is released there, and it is what gives you that feeling of euphoria, that up feeling, that feeling of pleasure. So again, the nucleus accumbens is also where the pleasure from food and sex registers. And what's really important is to remember that it's not an isolated structure that you can consider as its own little sort of silo. It interfaces with literally dozens of structures throughout the hindbrain, midbrain, and even the forebrain. So these are all interconnected, and that's why there's so much nuance, so much context, and so many caveats associated with talking about this kind of procedure. You really can't just consider the nucleus accumbens in isolation, although we sort of do that just to simplify so that we can at least articulate the theory of how this might work. All right, so I'm going to put in the video an x-ray from West Virginia University, which shows the exact placement of these DBS electrodes. So you can see the electrodes kind of come to like a V, which you can see is fairly deep into the brain. And that corresponds to the location in the striatum that's being stimulated on each side. So the electrodes feed into a cord, which you can see on the x-ray, and that is connected to an external controller. And that controller allows the scientists involved to vary the level of electrical stimulation. What's fascinating is that in one of the initial studies, there was a patient who got this technique. Basically, they had these electrodes implanted because they were in chronic pain, but they had a really intense history of opioid and benzo use, which is why they were selected, as part of the first cohort. Now, this patient was allowed to control the level of stimulation because originally the scientists thought, well, let the person fine-tune the level of stimulation because they know best what they're feeling, right? This person basically developed a sore on their finger because they were pressing sort of like the on button so much to stimulate, the electrodes, which in turn stimulated dopamine release. This woman basically showed interest in basically little else for the 2 years that she had control over the level of stimulation that her device was providing. She said the feeling that it gave her was quote unquote erotic. And because of this, they took away the ability for the patients to regulate the level of stimulation themselves. So, to show you guys what an absolute, what's the word I want? Not degenerate, although that applies too. Not dissolute, but absolute reprobate I am, like unreformable. As soon as I heard that she did that, I was like, oh God, I wish I had one of these. Like, how much more convenient would that be instead of like having to take a drug to stimulate the dopamine release or get laid or whatever? You could just press a button, like basically eliminating the middleman, right? But okay, total Brian tangent. Sorry, guys. So not surprisingly, there is a lot of fine tuning involved. So the electrodes get implanted, and it takes weeks to months for the scientists, based on what the patient is telling them, to get the right level of stimulation delivered. So if you overstimulate the area, and again, we're going to hear a quote from one of the first cohort patients later on, which is fascinating about what that feels like. But if you overstimulate, using the electrodes, you can create this, not just this euphoric state, not just this feel really good state, but like a mania that can lead to uninhibited and undesirable behavior. You could think of it in a very crude way as something similar to what might go on in the manic phase for a bipolar patient, although that is not a perfect analogy by a long shot. Now, if you don't stimulate the brain using the electrodes enough, it doesn't really do what it's supposed to do, and you get a patient who's depressive and who's still having cravings, thoughts of use, and potentially even giving in to those thoughts of use and relapsing. Okay, so it's a delicate balance, and the only way to get the right level of stimulation is fine-tuning through trial and error. So on the basis of the results that I've read about so far, it seems like there is an optimal level of stimulation at which you can basically greatly reduce cravings, anxiety, and depression, but you can still get the person feeling quote unquote normal, quote unquote like back to the state that they had, or an approximation to the state that they had before addiction, so that they don't just feel like artificially up and elevated. So it does seem that that balance can be achieved. And again, we're going to talk about direct quotes that support that later on. All right, so risks and patient selection for this kind of study. So there are huge risks involved with such an invasive procedure that involves opening the skull. I mean, when you're planting these electrodes, you are passing by neural structures that control almost every function that your body can perform. It's scary, you know? It sounds like, from what I've read, there's about a 1% chance of serious adverse outcomes, including death during surgery, stroke, bleeding in the brain, infection, and other permanently debilitating complications. This is in line, from what I understand, with the risks of the average neurosurgery, or at least it's not much beyond the risks of the average neurosurgery, although to say average for a surgery is a very difficult judgment to make. But it is a really high level of risk relative to most surgical and non-surgical procedures. So I should say surgical and non-surgical treatments. So for example, one thing I looked up was the infamous Brazilian butt lift, which is infamous as the deadliest procedure in plastic surgery. That has a fatality rate of between 1 in 2,351 patients and 1 in 6,241 patients. So those numbers don't include the rate of serious complications other than death, but still you can see like this is a pretty dangerous, relatively dangerous technique. So what it means is that only the most treatment-resistant, refractory, life-threatening cases of addiction are suitable for treatment with deep brain stimulation in its current form. So you're looking for the person who, like me, has had overdoses that brought them to a state where they would have been dead had medical intervention not happened in the next couple of minutes. And not just someone who's been there once, but someone who has gone through conventional treatment again and again and again and showed all the signs of trying really hard with both maintenance and without maintenance and just not being able to get it. So it's also important to keep in mind that opioid addicts who do eventually successfully achieve long-term recovery, they most often need multiple rounds of inpatient and outpatient treatment before they can do that. So you don't want to go to such a radical, dangerous technique too early on, is what I'm saying, which is a pretty basic idea, right? So you want to differentiate between addicts for whom existing pharmacological and psychological treatments simply will not work, from addicts for whom those treatments haven't worked yet. And that's a tough clinical call. It requires really knowing your patient, having intuition about their situation, but also knowing their history backwards and forwards and taking the time to ask them all the questions you need to ask them to judge whether, you know, they might be someone who just needs another shot at inpatient, or someone who needs to try maintenance who hasn't tried it before, versus someone who just like, that stuff really doesn't work. They're trying and it doesn't work. And it's not just the life-threatening complications that make me say that. So the brain's pleasure and reward pathways, they're intricate, super complicated systems. They evolved over hundreds of millions of years to modulate our behavior in really nuanced, interconnected ways. So when we tamper with them, we are absolutely venturing into brave new world territory. We're modifying systems with profound ramifications on regarding our motivations, our relationships, our spiritual life, and we absolutely, in terms of our current knowledge of neuroscience, it is burgeoning, but we absolutely don't know enough to be able to predict, let alone sort of limit the potentially permanent side effects of on personality and behavior of a technique such as this. So there's also a bit of like maybe not a paradox, but a contradiction involved in this type of treatment in terms of who needs it versus who will actually qualify for participation in these studies. Okay, so if you are an intractable addict who is the kind of person who would be most likely to benefit from this kind of very invasive technique, that means that, addiction destroys everything in your life. It means your jobs and apartments are unstable or gone. Your relationships decline. The support from family and friends dissipates. Like in every direction, you burn bridges. Things fall apart. That's the person who needs this treatment, right? But unfortunately, in order to be enrolled in a study such as this, you need to be able to show up for regular long-term follow-up appointments. You need safe, stable housing where you can recuperate from a major operation. You also need transportation to and from those many follow-up appointments. And you also need the financial security, either through, maybe it could work if you were on disability, but if you're working, which most addicts are, period, you need to be able to take extended time off of work without disrupting all of the aforementioned. So your housing, your transportation, etc. So summary is very few addicts who will benefit from the procedure have stable enough lives that they'll qualify for it. So what I was thinking when I was doing this research was that maybe eventually, if this technique is scaled up, there could be something like a halfway house system where once you're approved, ideally through Medicaid or public insurance, once you're approved, you can get residents in some kind of like a halfway house where you can reside and get free transportation as you are undergoing the procedure, and then the fine-tuning afterward and waiting for the longer-term effects to manifest so that you're more stable and you can go out on your own and resume being a productive member of society. So that was one thing that occurred to me, and compared to just sending someone endlessly through inpatient and outpatient, it would be a hell of a lot less expensive just to have that for a year for them rather than a lifetime of in and out of ineffective treatment. Because I didn't stress it enough before, but the treatments that we currently have, especially for opioid addiction, are so incredibly ineffective. We wouldn't accept this high of a mortality rate for any other group of patients. If cancer were killing this many people, we would not accept it. Simple as. Okay, before I get off track there, let's talk about the outcomes. So there has been significant variation in individual outcomes in the early cohorts for these studies. So there's a paper published in the Journal of Neurosurgery in 2023, and that gives the results of the small initial cohort from West Virginia University. They summarized the results as follows. Okay, they said 4 male participants were enrolled and all tolerated DBS surgery well, with no serious adverse events and no device or stimulation related adverse events. 2 participants sustained complete substance abstinence for greater than 1,150 and greater than 520 days, respectively, with significant post-DBS reductions in substance craving, anxiety, and depression. 1 participant experienced post-DBS drug use recurrences with reduced frequency and severity. The DBS system was explanted. It was taken out in 1 participant due to noncompliance with treatment requirements in the study protocol. Very intriguingly, FDG, so PET, that's a brain imaging technique. It's fluorodeoxyglucose positron emission tomography. Basically, it shows the level of activity of different structures in your brain. So this neuroimaging revealed increased glucose metabolism in the frontal regions for the participants with sustained abstinence only. That last sentence is so important because it shows in the people that this worked for, it seems like brain physiology is shifting in a way that indicates recovery of executive function, recovery of that prefrontal cortex that I talked about in the beginning of the video, which controls impulse control, long-term planning, delayed gratification. There's more activity of that area of the brain in the patients for whom this technique worked. So that will happen naturally to some degree with recovery from addiction. So I would want to look at what is the level of, sort of increased activity of the PFC and other areas in people who have had this technique versus people who recover, say, without it. But still, it's promising. It means that they have an ability now to restrain themselves. They have an ability to make logical decisions, to again control their addictive impulses that wasn't there before. So very intriguing stuff. So the distribution of outcomes because when you read a study that has 4 to 8 participants, these are, and can't talk today. Should have emphasized this more, but these are incredibly preliminary results. The statistical power of a cohort of several individuals is incredibly limited. We really can't draw robust conclusions. It's anecdata at this point, and it's limited anecdata. However, the distribution of outcomes in this West Virginia study that I keep talking about is consistent with those reported by a Chinese research group, which used a very similar DBS protocol. That Chinese research group, and again, the link is in the description below the video, it reported that out of a cohort of 8 patients with severe opioid addiction who underwent the DBS implantation procedure, 5 of them remained abstinent for at least 3 years of follow-up. 2 relapsed after 6 months, and 1 patient died of an overdose 3 months after surgery. So in 2 different studies, in 2 very culturally different countries on opposite areas of the globe, the distribution of results was pretty consistent. So that leads me to think that the West Virginia University results are probably not extreme outliers. So it leads me to think there is some validity that we can extrapolate a little bit further than we typically would from phase 1 trials. So I want to talk about specific people and what they had to say about having these things in their brain, okay? So again, the DBS treatment, it didn't work for everyone. We haven't progressed to a phase 2 clinical trial, which will involve a greater number of participants. I'll talk about that a little bit more at the end of the video, the current status of this study. But for now, we can see that a sizable proportion of the people who participated in the phase 1 small cohort studies did benefit from this. So one of these participants, the very first patient, was named Jared Buckhalter, and in a 2020 Vice interview, immediately after the procedure to implant the electrodes, he said he felt, so I said that weirdly. This 2020 Vice interview wasn't immediately after he had the procedure. In this Vice interview, he was talking about how he felt immediately after, and he said, quote unquote, I felt really, 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 really good. 4 reallys, okay? So as they fine-tune the level of stimulation from the electrodes and his brain adjusted to the hardware over the following days and weeks, Buckhalter reported a return to a baseline state that he hadn't experienced since before his addiction. He said he was free of depression and anxiety, and he just felt normal. Now, I've searched for more information about his outcome. He had a flurry of interviews that he participated in from 2019 through 2022. But I couldn't find any really recent documentation about how he's doing. But in that Vice interview, which I think it was actually from 2021, he did mention that he was working with other patients in the WVU program. And in the 2022 CNN interview, he reported that he had been stable for 2.5 years. So this is pretty long-term stability at that point. So another quote from Jared is, before, I just didn't do anything. Nothing brought joy to my life. He said that now he takes pleasure in ordinary activities again. He said, once in a while, I'll have a few cravings. They don't last very long, and they're not so strong that I contemplate acting on them. Before, I couldn't process thinking of the consequences. He said, and this is my summary of what he said now, not his exact words, basically that his impulsivity has been greatly diminished post-procedure. He also mentioned, again, this is one of the most interesting parts of this whole deal for me, that his fear of public speaking and some other just small quirky anxieties have hugely dissipated following this kind of electrode stimulation. So one thing that I need to emphasize is that we need more information on how opioid maintenance treatment with buprenorphine and methadone interfaces with this kind of DBS treatment, because Buckhalter is still on Suboxone or buprenorphine. The procedure was mainly undertaken to control his rampant use of benzos. So like me, he is a combination benzo and opioid addict. I have talked many times. I have separate videos about how bad my Xanax addiction was and how it's caused more damage to my life than my opioid addiction. And yeah, it's a deadly combo. So mainly for him, it was about controlling the benzo use, and it did work very well for him. Again, 2.5 years of stability, but he's still taking buprenorphine, and that's significant. Okay, so again, we need to sort of parse out how much of this is from the maintenance and how much of this is from the DBS. Now, it's likely that the efficacy of the DBS treatment is substantially impacted by whether or not the person is also using maintenance, which in itself is the most efficacious treatment we have for opioid addiction right now, is just to keep giving the person opioids. And it'll be difficult to gauge whether the procedure has other desirable effects, such as attenuation of withdrawal and opioid cravings in patients who are on opioid maintenance, because the maintenance itself has a huge effect in ending withdrawal and in reducing cravings. So you can take a patient who's stable on maintenance and say for them afterward, they still experience much reduced cravings, but you can't extrapolate that to a patient who's not on maintenance to begin with. We don't know that it would have the same effect. So there's another patient named James Fisher who I want to talk about. He was the third patient of the WVU study, and he was also addicted to both benzos and opioids. So shout out to you, James Fisher. I know your pain. And he also had like what I would call extraordinary results. He said, quote unquote, it's like night and day. This is from a 2021 interview with NBC News. He said that he felt, quote unquote, fantastic, and that his depression, anxiety, and irritability had been replaced by a calm contentment that felt, quote unquote, like a warm blanket. Now, that NBC interview that I'm talking about was conducted only 3 months after he underwent the procedure, but at that point, Fisher said he had no cravings to use drugs. He talked about it like it was kind of a miraculous effect. So again, that's short term in one person who, to be fair, probably felt a lot of pressure to emphasize the positive effects of this treatment, I would think. Okay, now there's another really interesting case. There was a Canadian AIDS researcher, famous researcher, whose name was Frank Plummer. He was a really severe alcoholic. He was such a severe alcoholic that they gave him a liver transplant, and he kept drinking afterward. So he had this DBS surgery in 2018. Afterward, he reported great subjective improvement in his inner state, so how his level of contentment, basically, as well as he said it gave him the ability to moderate his drinking for over a year, which he had never had before. He was a kind of alcoholic who, when he started drinking, it was roll of the dice, you know, when he would stop and how much stupid shit he would do before that happened. So he said that this gave him an unprecedented ability to limit his intake, which is in line with what we would think would happen when you're increasing dopamine in the nucleus accumbens. You are limiting the reward you get from taking in a substance that you're addicted to, because you're kind of giving yourself that stimulation already. So we would kind of expect that, or we would hope for that at least. So the thing is, in the case of Frank Plummer, we have a limited time frame for assessing the impact of this technique, because he died of cardiac arrest in January of 2020, which was, I think, a year after the procedure was performed. So one other really fascinating quotes and testimony from these first participants in these studies. We'll say that again. One concern that I have that I should mention before the end of the video that I haven't given time to already is that if you get this procedure and it doesn't work for you, I think there's a chance it could actually make you worse. So for one thing, like, okay, so again, you get the procedure, it's not reducing your cravings, your impulsivity, and your using behaviors, but it is blocking or mitigating some of the usual neurochemical reward you get, the high you get, that dopamine release you get from taking drugs, okay? And because of that, you're not getting the effect you want from the drugs. I could see it pushing people into using dangerous amounts, which could increase the risk of overdose. It could also potentially, what you see as a lot of cross-addiction and other addictive behavior. So just like, 1 in 5 people who get gastric bypass surgery end up with an alcohol problem or another substance abuse problem. If you remove someone's coping mechanism, they can go to another unhealthy coping mechanism, maybe gambling addiction, maybe compulsive sexual behavior, or just all types of bad coping mechanisms, harmful coping mechanisms. They might also turn to substances whose action is a little bit different, so that they don't really need the nucleus accumbens to get the high that they want from it, because there are substances addictive substances that aren't as effectively blocked by this kind of nucleus accumbens centered DBS procedure. So again, when I talk about this too in the context of 12-step programs, when you take away someone's chief coping mechanisms, which in the case of someone like me has been their whole way of dealing with stress and anything negative or positive in the world since they were like 12, you can kill them, you know? So I think there's a chance if this procedure doesn't work for you that it could make you worse. And that might be seeing what we saw in that Chinese cohort with a participant who overdosed very early on in the timeline after getting the DBS setup implanted in his brain. So what does that mean? Well, it means we need larger scale studies, and that hopefully that will help us differentiate which subpopulations of addicts will benefit from this DBS treatment versus which addicts we need other types of interventions for. And again, given the low efficacy of existing treatment options, like even if this didn't work out, it's worth doing. And actually, these initial results are pretty robust and encouraging. And who knows, like maybe someday when they're opening someone's skull up to implant the electrodes, they're tinkering with the nucleus accumbens, which is a process that the patients are awake for, by the way. They'll find some amazing, unexpected effect that gives us new insight into addiction or OCD or Parkinson's or who knows what. You know, a lot of really important discoveries in science, from penicillin to certain surgical techniques, are the law of unintended consequences in action in the best possible sense. So there's huge value to this type of experimental treatment, even if it isn't borne out by immediate efficacy. So quick note is I looked into the current status of this West Virginia University DBS project. So there was extensive media coverage surrounding the first cohort in 2019 to 2021. And after that, the available information fell off pretty quickly. So I was able to find a couple of papers, again, published as late as 2023, which summarized the results of that phase 1, that first cohort. But nowhere have I seen mention that the study has progressed to phase 2 trials, which involves, again, more extensive, larger cohort experiments. So there's a 2023 summary of research at the West Virginia University Rockefeller Neuroscience Institute, which mentions that the DBS study is no longer seeking participants. That makes me think there's been a disruption in the funding or more serious problems with the project. Now, it's possible that COVID played a role in delaying the timetable, but my overall impression is that the project began with a lot of media fanfare, but might have run out of steam due to cost, feasibility, limited efficacy, and just the level of intervention maybe putting people off that they would have to have their skull opened up to participate in this. What I should mention is I have an email into them, and if they clarify the status of the project and it's different from what I just surmised, I will I'll edit the video description rather to include whatever I learned from them. Now, intriguingly, the final thing that I'll mention is that West Virginia University is also pioneering a first-in-the-world treatment for addiction, which uses ultrasound waves to targeted at the nucleus accumbens, so the same structure in the basal forebrain that we're talking about today. Those ultrasound waves are aimed at the nucleus accumbens, and this is a treatment intended to reduce addictive cravings. So unlike the DBS procedure, this doesn't involve opening up the skull. Like, you can do it exteriorly without a lot of risk or damage. So this is fascinating, and as the results on that technique come in, I will probably make a video about how things are going. So I hope you guys enjoyed this video as much as I did. If you have any questions about anything I've said, just drop me a comment and I will do my best to answer it. Again, the sources are linked in the video description. I find this stuff fascinating. The next 2 videos I'm making are a review of Kat Marnell's addiction memoir, How to Murder Your Life, and part 2 of my Kratom series. But after that, I would like to make another neuroscientific video like this, depending on whether there is interest. So yeah, please consider liking, subscribing if you're not already, and I hope everybody is having a good day. If you're not having a good day, I hope that this at least gave you a little distraction and diversion. I love you guys, and I will catch you next time.